Well, good morning, everyone. Thanks for joining us for our third Direct Primary Care Clinic webinar with us here at the Alliance and Proactive MD. My name is Melina Kambitsi. I'm the Senior Vice President of Business Development and Strategic Marketing here at the Alliance. So before I introduce Justin Lay, who is our speaker and my co-presenter, I want to let you know that you're all in mute mode. And if you have any questions during the webinar, please send them in the chat box. If you want to say something or respond to someone during the discussion, please raise your hand. So the little hand icon shows a green arrow pointing up. Now, I'm very proud to introduce our speaker, my co-presenter, Justin Lay. Justin is the Executive Vice President of Direct Care Services at Proactive MD. He's passionate about improving the primary care model to better service patients and also improving access to individuals as well as small, medium, and large business clients. Justin is committed to the national expansion of direct care services and direct primary care and to the Proactive MD promise of always looking out for what's best for the patient. During the last portion of the webinar, we promised you last time that you'll be hearing from the same employers from our June 25th DPC webinar to help answer more of your questions. We had such an incredible participation and great questions, and our employers have been very gracious to join us again. We're gonna bring them in towards the at 11 o'clock, 11:30. I'm sorry. Those speakers include Dan Ludwig of Breakbush Brothers, Tina Hoig of Advanced Laser, and Jake Nolan of Rice Lake Weighing Systems. So thank you to everyone who submitted questions. We already have several great questions that we will answer at the end of the presentation. And so without any further ado, let's begin, shall we? So what Justin and I would like to talk to you about today is discuss high-value primary care. Why have we chosen specifically a strategy within the umbrella of high-value primary care that we call direct primary care? Also, who is Proactive MD, how the Alliance chose Proactive MD, present to you the Proactive MD solution, how are we different between the Alliance and Proactive MD, how do we present a different model in the market, and of course then how can we help? So what is high-value primary care? And the graphic that I have here on the right-hand side of the screen, many of you have seen before. The Alliance is the voice of self-funded employers. We have our mission, our imperative is to provide high-value health care for the employers we service. And we all know that care starts with primary care providers. In fact, over 80% of patients with chronic conditions access primary care, making it the most prevalent type of office visit. And when in fact, it is the most affordable type of service, the least expensive. What happens, however, with our systems today, many misaligned incentives, payment incentives, lack of behavioral health integration, and also lack of appropriate referrals, both to potentially inappropriate testing, but also to specialists, drive up costs and compromise the effectiveness and also compromise patient satisfaction. So at the Alliance and with the aid of actually research that we did with the Alliance and at the Alliance and with Proactive MD for the past year and a half, speaking with a lot of the brokers, consultants in the market, speaking with a lot of our employers, speaking and spending time with the National Alliance of, which is the broad umbrella organization of all the coalitions in the country, in the United States. We have identified some key characteristics that we want to bring to the market that comprise high-value primary care. The first is evidence-based medicine. So we want our care teams that take care of our patients to ensure that patients receive evidence-based care and that treatments and providers consciously avoid test orders not linked to change management and to evidence. One of the reasons why the Alliance chose Proactive MD is because of their experience with both small and large clients alike, and because of the fact that they have created standing orders and protocols, particularly when it comes to taking care of patients with chronic disease management. The second characteristic is risk-stratified care management. So each patient needs to receive care based on his or her unique needs. And of course, high-risk patients need longer office visits. They also need care beyond the walls. We'll hear Justin talk about the care beyond the walls of the health center, which include monitoring and guidance from a care management, phone checks, on-site meeting, on-site employer visits, etc. Then a third characteristic is care coordination. I look at client data almost on a daily basis, and it's remarkable to see how often we, through our analytics capabilities, see a lack of care coordination from our client data. So care teams need to monitor patients outside of primary care visits and ensure that patients complete specialist referrals, the necessary tests, the necessary procedures, schedule time follow-ups following a procedure, and as importantly, track medication adherence. Next, very important, is care navigation. And with care navigation comes very careful selection of specialists. We know today that many large and small employers alike spend additional dollars in selecting care navigation vendors. And so our vision for a primary care offering is to actually include that care navigation and the careful selection of specialists within our walls. Clinicians need to be using a narrow list of specialists with whom they trust the care of their patients and with whom they remain in constant contact as treatment plans develop. This is where the very crucial integration between the Alliance and Proactive MD takes place. And so at the Alliance, we have 30 years of cost data because, as you all know, we have direct contracts with providers. That gives us all the cost information. There is a pipeline integration between us and Proactive MD. Proactive MD then uses algorithms to assess quality. And between cost and quality, we now have the ability for the care team to be navigating our patients to the very best, to the highest value of providers. So many DPC offerings today lack organizational infrastructure. Many primary care offerings actually lack organizational infrastructure. And so the analytical and reporting capabilities, meaning EMRs, coordination and communication with other providers and with payers, continuous staff improvement and training is another very important characteristic for the offering that we want to bring to the market. And then let's talk about compensation of providers. There needs to be a balanced compensation that's based on quality and value, as is defined by the patient experience, patient satisfaction, and also the satisfaction of the employer, vis-a-vis instead of volume. So we want to be rewarding our care management teams based on care quality, the patient experience, resource use, and referrals. So these are all the reasons, and forgive me, and of course at the end, I keep forgetting this, few referrals outside of the primary care ecosystem. I forget this because I keep talking about this throughout this presentation. The numbers that are critical here in terms of referrals outside of the walls of the primary care ecosystem should be less than 10%. In fact, you will hear Justin today say that their average for Proactive MD, their average referral outside of the clinic is between 7 and 8%, 7.5%. These are the types of numbers that we want to develop for our clients as well. So these are the reasons why we've chosen direct primary care. We call this very specifically DPC. It's delivered outside the traditional health system. It has different incentives. DPC improves patients' health and lowers the total cost of healthcare. Our expectation is that the total cost of healthcare will be lowered by about 15%. Again, more numbers that we will see here in a few minutes. DPC is a patient-centered care for the whole family, and it is actually a membership-based model. So no insurance required, and pricing is transparent. Part of why the Alliance chose Proactive MD is because Proactive MD can bring this flexibility, patient-centered care of with a membership-based model with no insurance required and pricing that is transparent to the market along with the Alliance. Instead of aiming to generate then more specialty care, our system exists to generate more health for the employees, for our employees and their families, and also, of course, for the employers who sponsor their health benefits. And in fact, in Wisconsin, many employers have embraced the DPC concept. This is how we, my team, myself, the executive team here at the Alliance, we learned more about the DPC concept through the efforts of many of our clients. And again, these are the reasons we chose Proactive MD, who can deliver the personalized care of DPC with a comprehensive infrastructure of the on-site, near-site offering, which has traditionally been offered to very large employers. So with that, I would like to turn it over to my colleague, my friend, my partner in crime sometimes, Justin Lay from Proactive MD.
Thanks, Melina. Yeah, I really appreciate everybody joining us today. So as Melina said, I'm Justin Lay with Proactive MD, EVP of Direct Care Services. We wanted to start off with just a little bit about Proactive MD. So we are a primary care organization that partners with large and small clients, benefit consultants, and benefit brokers to really solve some of their most challenging healthcare problems, all wrapped around a primary care solution. We've been in the value-based primary care space now for around 10 years, servicing large clients and small clients. Currently, we operate about 60 locations. We serve both public and private sector, everything from cities, counties, schools, through manufacturing, you name it. You know, the company is headquartered out of Greenville, South Carolina. We have a large operations center and footprint in Indiana, and we're rapidly expanding up through the state of Wisconsin, all the way down through South Carolina, North Carolina area. So if you think of our footprint on a map, you know, go to northern Wisconsin down to South Carolina. That's our planned footprint for the future. But we can service really any area geographically speaking with an on-site, near-site solution, and then where we have, and I think we're focused today mostly on the direct primary care model, where we have existing footprint or where we're launching health centers. We're really excited about talking to more groups, more brokers, more consultants about how we're bringing health centers to certain areas and how that makes it easier to take advantage of a primary care solution. If you think about it, I think our core philosophy at Proactive MD, it's all centered around our patient promise, which is it is always about the patient. We started with that. That's our one true North Star value that we'll always adhere to, and then we built a solution around that very concept. So we wanted to start with a little bit about our approach towards the DPC model, on-site, near-site, value-based primary care. It's got a number of names. I think we've modeled our front-end service delivery, care delivery model around a true DPC approach. And when we say true DPC, what we mean are very small patient panel sizes designed so that our physicians are seeing no more than about 10 to 12 patients per day. If you look at a lot of the issues with healthcare and with primary care specifically, a lot of it can be tied to volume and providers that are seeing too many patients per day to properly manage and care for their patients. So by simply solving for the volume issue, we can give individual providers more time with their patients, which allows them to do a lot more. If you combine that with then a lot of convenience factors by managing small patient panel sizes, you end up with easy appointment availability. So we deliver appointments almost same day, over 99% of the time. You look at short wait times. Our average wait time is well below 5 minutes on average. That's a metric that we pay very close attention to. And the model in and of itself is convenient for individuals because we also eliminate all copays for encounters. So individuals can use services once they're members as much and as often as they want, and they can have as much time in the exam room as they would like with their providers. And this is all by design. This is by looking at what we could do with primary care and figuring out how can we get the most out of this model. And to get the most out of it, We have to manage patient volume to a level that allows providers to practice at the very top of their license. We have to reduce patient volume to make sure that we can spend that extra time in the exam room to help individuals, not just with their episodic events, but to truly manage them, to focus on their chronic conditions, to focus on their wellness and long-term health, to do whatever we can from a primary care standpoint to give individuals the best access to primary care possible. On the back end, we've been servicing larger self-funded clients for about a decade now. And through those years of experience, we've learned how to service larger clients and the things that they will need. So on the front end, you get a great primary care model. On the back end, we have a fantastic data science team that works in collaboration with the Alliance to do all of our claims analysis and claims reporting. This allows us to risk stratify entire organizations, to identify at-risk members, those who have prospective, who are your prospective high-cost claimants, those who are your chronically sick, and those who are your medically homeless, who we simply know nothing about. By risk stratifying across an entire population, we can start to engage in true population health measures. We can do targeted outreach. We can do condition-specific efforts to try and customize what that outreach effort might look like. We use patient advocates in every single model and every single health center that we launch on a direct primary care platform. Those patient advocates are part engagement specialist, part care team, and then part care navigator for the individual. So they are really the secret sauce to what makes everything work better in our model. And they're designed also to work alongside our data team when we're looking at how we identify the population and the individuals within that population that we can help and benefit the most to drive better outcomes and do better cost containment. So, I think in a nutshell, we've designed a model that's DPC on the front end. Again, it's low volume, high quality primary care designed to do as much as you can in a primary care model. On the back end, we're designed to service clients of all sizes through in-depth reporting and strategic outreach initiatives. And then once you tie it all together, I think it creates really the best of all worlds. It's a great enhancement to a company's employee benefit offering by offering employees now unlimited access to high quality primary care without any of the hassles that typically come along with primary care, and really managing hopefully the best patient experience they've ever had. So it's a great enhancement to employee benefit offerings from that perspective. Meanwhile, we feel like it's the most cost-effective solution you're going to get out of an on-site, near-site DPC approach. Not just because of an optimized care model, but because of all the back-end strategies that we can tie into a primary care model to make it all work. And we'll get into some of those details as we move forward. So if you look at, I think, the key aspects of what makes our solution work and what makes us different, starting with broad scope primary care. So just putting a licensed provider in an exam room with a patient really isn't enough. We have to hire providers that have a passion for caring for people. They're often typically frustrated with the status quo of the current health system model. They're trained to manage chronic disease. They're trained to practice at the top of their license, as we said. And we really hire first and foremost providers that want to be in this model, that understand the problems with the existing high volume fee-for-service world, and who simply want to do more for their patients. And then we give them an environment to do that. So we look for the right providers who understand the problems that we're trying to solve for, who want to be in this model. We hire them, and typically there are a number of them that want to be out of that world. And then we make sure that we support them with whatever they need to really then deliver the best care possible for patients. We talked a little bit about patient advocacy. It really is one of those roles where once we plugged it in and started using it, we found a number of ways to then further optimize that role. It's something that we believe in passionately, that every patient needs an advocate. They need personal relationships, and they need assistance even when they're released from our health center. And so that's what the patient advocate is designed to do. They are typically licensed clinical social workers, and the reason why we like to use social workers for our patient advocacy role is, one, because they're engagement specialists on the front end. They need to be able to network within our client's workforce, meet people, build personal relationships, start to build trust among the population. And then by building trust and getting to know the individuals within the workforce, it makes it a much easier conversation when we do find somebody who really needs to use clinical services to get them in and to get them seen. So it's very much relation building at first, and then it's a transition then to getting the individuals who we can help the most into the health center. Once they're in the health center, the providers absolutely love working with patient advocates, because when they do have to make a referral, and Melina said it before, we refer at less than 10% into specialty care typically, but when we do have to make a referral, those patient advocates are also there to support the patients once they leave our care. So when we talk about care beyond the walls, that's what we mean. We release as little as possible into specialty care. Only what's necessary to go into specialty care do we refer out. And when we do, the patient advocate is there to be that educated healthcare consumer for the individual to help them with their healthcare journey. That results in a lot of additional cost reduction and cost containment, because now individuals are making smart, educated consumer decisions, but not at risk for making the wrong decisions, because we have an expert that's there to work with them. Service delivery is a huge component of our care model. Not only are we providing a model where they're getting great access to great providers and great quality care, but there's a big customer service piece to this, because we have to make sure that it's the best patient experience that they've ever had. And it usually, we have some inherent advantages when you don't have to make any copays for services, when you can always get in same day, when you don't have to wait, and when you get plenty of time in the exam room. That alone is typically enough to make very happy patients and keep them coming back for more. When you add in very specific customer service training, so that the staff is warm, friendly, welcoming, and really, delivers great care with a smile on their face, it really does change the entire patient experience to one that they can't stop talking about. And that's what we want. We want them to go back to their place of work and say, guys, this is everything that we were told it would be. It's not too good to be true. Not only that, but I love working with the care team there. I love from the admin assistant and the scheduling process, to working with the nurses, to working with the provider. Every touch point is a critical one, and we want to make sure that that's a great patient experience from beginning to end. And then all of this is done, and we recognize that most clients who are interested in a clinic model want to see a return on investment. They want to do this. They love the idea of enhancing their employee benefits, but they need to see savings. And that's the other piece of this. We will put forward very strong performance guarantees to help clients feel comfortable that they're going to see savings by using and working with Proactive MD and the Alliance. So we'll put performance guarantees behind that. And we've also designed some pricing models that also eliminate a lot of the risk associated with a clinical approach and a clinical strategy. We'll talk more about that later on. But again, I think that all the things that we've talked about, from broad scope care, patient advocacy, care beyond the walls, and service delivery, all of those lead to high engagement and a quality care environment, which does lead to an ROI. And then the ability to contain and to release as little as possible into specialty care is what truly drives savings. I think the care that we deliver dollar for dollar, there is some savings there, but it's what we avoid that really drives the majority of savings. And on the screen, you'll see some of the areas of impact that we usually hit and see that the best results in. Office visits is an obvious one, but 20 to 40% of reduction in emergency room visits. And that's because they have access to a healthcare provider 24/7. And so before they use the emergency room, they can reach out and contact us first, which helps reduce emergency room visits. A lot of emergency room visits are actually done 9 to 5 Monday through Friday, even the avoidable ones. So there's this thought that a lot of them are just nights and weekends when primary care isn't available. That is the case, which is why we make access and 24/7 something that is part of our model. But a lot of that is just by simply having a convenient access, even 9 to 5 Monday through Friday, will have a dramatic impact on emergency room utilization or unnecessary emergency room utilization. Less outpatient, less hospitalizations, reduction in pharmacy claims. We do dispense medications in almost all of our health centers. They're about typically, anywhere from 80 to 100 common generic medications available. Most of them are at no cost to each individual member. If there are some more expensive medications that we can dispense, we would pass that cost to the patient at whatever our cost is. But about 90% of what the patients would typically be dispensed is available and is a part of their membership, so it would cost nothing extra. Same thing for lab services. The majority of labs that we offer are included in the membership price, and anything that would sit outside of that we always offer at our cost. If individuals have insurance, we can't always refer them outside. We can write prescriptions, we can order labs, and they can still use their insurance if they have insurance. So patients also have a choice in that process. And then imaging is something that we can impact significantly. A lot of imaging, a lot of images that are ordered are completely unnecessary. And so as long as providers are practicing conservative care, meaning using the information and the data that they actually need to manage the patient, we typically see just as good outcomes without a lot of unnecessary tests, procedures, images, etc. That would be a part of our model. There's no administrative pressure on our care team to refer. There's no administrative pressure to order. There's none of that because we are untethered to any health system, and we have no perverse incentives to try and drive any of that volume. We are looking out for our clients and your bottom line, and we're also trying to avoid any unnecessary care that patients don't need, which again is a much better overall experience with their healthcare journey. And then the last piece, we talked a little bit about what we wanted to do for return on investment. But we also recognize that a lot of our clients that we were talking to, there were several that were interested in a clinical model, but they would typically have two reservations. The first reservation would be the large upfront capital expense to build out an on-site or near-site clinic. The second reservation was that they would pay for the solution without certainty that individuals that are on their insurance plan would actually use services. So we created an engagement-based pricing model to address that concern. First, we're bringing health centers into communities. And so what we hope is that as we're launching more health centers, groups that are within our service area would see that they don't have to build out their own health center. They can just use one of ours. If they need a health center and they want one on-site or near-site and they want to build one out, we can also do that. We service larger clients and single client health centers as well. But by bringing health centers into the community, it allows groups to take advantage of the clinic that's already there, so they can avoid that large capital expense on the front end. And then an engagement-based pricing model means that you're also only going to pay for those members who are actually using services. So traditionally, you would pay, it would either be done on a fixed fee or a per member or per employee basis. You would calculate the number of individuals that were on your insurance plan, the employees, the spouses, and dependents, and then you would pay based on those numbers. And that puts clients at risk for what happens if individuals are not using services. So an engagement model means that we're enrolling individuals one at a time as they use the health center. So not just individuals who are opting in, who are saying that they would use the service, but we don't enroll them and we don't charge for them until they actually show up for their first appointment. So if you look at an eligibility file and you start off with everybody being eligible to use the clinic, you start off by paying zero. And as individuals use, we enroll them one at a time. And so this also allows for your cost to slowly ramp up over time, and then also only exceed what you would typically pay for a clinic solution if you hit high utilization numbers. If your utilization is low and we never hit our typical target numbers to drive utilization that would produce an ROI, your cost will also stay low. This gives clients protection against low utilization. If only 10 to 20% of your workforce were to use services, then your cost is going to stay correlated with that utilization. This allows clients to get return on investment even with low utilization. Traditionally, you would need to get to about 50 to 60% engagement and utilization among individuals on the plan to see savings. We can now get there with far lower engagement numbers than that. And so the higher the engagement, the higher the savings. Then the higher the engagement, the more proactive MD makes. So now our goals are aligned that we don't get fully paid unless we are driving engagement levels to where they need to be, and clients have some protection against low engagement from a cost standpoint. This also eliminates the need to wait 3 years to evaluate performance and then to try and fight over a performance guarantee. You get it right away. It's front loaded. You pay as you go, and costs ramp up over time, which creates a much easier entry point for clients who have some of those typical reservations. So again, in summary, we've eliminated the upfront cost when we bring health centers into your community, and we've created a model that protects you against low engagement and also slowly ramps cost up over time as more and more individuals use services. I think we're confident enough in our ability to drive engagement and to create a great model and a great patient experience that we know individuals will use the services. And so, we can put our neck out there a little bit and take some of that risk off of our client's plate and absorb that ourselves, because it's our job to get individuals to use services, and we're confident in our approach to do that. And then as far as services are concerned, So when you think of primary care and what services our health center models provide, it's really anything that a primary care physician can offer. It can be, anything in terms of your traditional corporate wellness programs, and anything in terms of referral management. So if you're doing anything traditional corporate wellness, we can do your screenings. We can even support your health risk assessments. We can even work with third-party wellness vendors. We provide lab services, so all the typical blood panels that would be a part of a screening we offer. They're included in the membership price. And we offer physicals and wellness visits as well. Diagnosis and treatment. Of course, we're engaging individuals. We can do episodic care as needed, but we're really focused on not just doing episodic, but making sure that we're also managing chronic conditions for individuals. And we can do any kind of first aid, suturing, skin conditions, injuries, you name it. Like I said, if it can be delivered by primary care, we offer it within the health centers. And then, of course, we said chronic condition management, and then also care navigation. Again, when we refer a patient out and they're seeing a specialist, or they have to go for a procedure, the patient advocate is always there for them, helping them with care navigation. If there are any additional strategies, such as the alliance or anything else that the client is trying to integrate as part of their plan design and cost containment strategies, we can also enable those solutions to be more effective. If you have a third-party wellness vendor, we can work with them to make sure that their program is more effective by having a primary care component to help manage those individuals who we're discovering through a screening process. If there are any solutions to whether it's a direct contract or anything else, our care teams are mindful of some of those unique components of your care or of your plan design. So all of that is the services that we provide in the clinic are listed here, and then there are additional services that we provide outside of the health center, again, to just make this the most effective cost containment solution possible. We talked a lot about patient experience, and so to recap that and how we really wanted to draw up what would be the ideal patient experience. How can we create a situation where every time somebody uses our health center, it's unique and it's different than anything else they've ever experienced in primary care. So starting with the basics, easy appointment scheduling and availability. You call us, you can get in same day. You're not going to be waiting 2, 3, 4 days or sometimes several weeks like you might often experience in the fee-for-service world. It's a very simple and easy check-in, check-out process. Once you get established, we know you by name, so your provider should not need to read your chart to know what your first name is. We really want to create personal relationships with individuals when they show up. It's a simple in and out process. Our average wait times, as we said before, are less than 5 minutes. Most of the time, individuals can call us, get in, show up, and go right into the exam room and see their provider without having even a wait time at all. Friendly staff that believes in customer service. We train them on customer service, not just in great care, but what a great experience should actually be. We extend that through the provider visit, so the providers are also trained for customer service as well. And then we will also want to make sure that as we launch new health centers, we really want to focus on becoming a part of the community, to understand what community resources are there, to support any other local healthcare initiatives or things that align with our mission, vision, and values, and just to also not just know the resources, which helps patient, but to integrate with the community and to be a part of the community. And then ongoing support. So when you think about the patient experience outside of normal clinical hours, we offer virtual visits. So if it's inconvenient for them to travel in, we can give virtual visits away. This has become, especially, I think, popular during, COVID events that we've all been experiencing. We also offer after-hours services. So once the health center is closed, individuals still have access. We have a 24/7 hotline, but also we make our providers make themselves available after hours as well. And as we said before, we offer on-site medication dispensing and lab services. There's some savings in medication dispensing, and there's certainly some savings in the lab services that we provide. But more important than that, it's a convenience component. When individuals show up and they can get right in, see their provider, and walk out the door with medication in hand, lab services done, and you can do it in 45 minutes or less often, unless the patient wants to spend more time. They can get in, they can get out, and they can get the most thorough exam possible in that amount of time. So that's the patient experience in a nutshell. It's part quality care, part customer service, and part just making sure that all the services that we can provide from a convenience standpoint are provided as part of that experience. And that all leads to, again, going back to not only an ROI, but just a great enhancement to your employee benefits. Giving them this type of access to care will have employees loving this, regardless of any other components of your insurance or other benefits that are available.
Right. So we would love to talk to you. So Justin and I have been talking to many brokers and employers the past few weeks. One of the questions that we got in is if we have any clinics operating in Wisconsin, and the answer is we do not. We work with employers that are interested right now for us to open up our first clinic in East Madison, most likely the Sun Prairie area. A few things that we would like, Justin and I would like to further note here. So we work with your brokers, your consultants, our consultants, who serve as a strategic partner with the Alliance. It is their job to, of course, review claims projections reports with us and with you, with the employers, to understand the potential clinic impact. And in fact, Justin's organization, ProactiveMD, and also the Alliance science team, data science team, are standing ready to, based on some of the numbers that we know come from the ProactiveMD experience, we're standing ready to show you the potential clinic impact. Of course, the consultants advise on how to best incorporate clinics into the overall benefit strategy, and of course recommend the solution to employers and actually the C-suite of our employers. So this is often a CFO, CEO discussion and decision above and beyond the HR team and the brokerage team. So what the employer is expected to do, of course, is sponsor the clinic. We need employers to promote and incentivize clinic usage to employees. Our offering, first of all, a couple things. Our offering, first of all, doesn't have an Alliance box around it. So we are open to all employers, self-funded or fully insured, that want to participate. We're open to individuals who would like to participate. So it was very, our choice of ProactiveMD was very specific to their flexibility to allow communities to participate. So then, of course, the employer pays a per member per month and fee instead of a bill for each service. So at the Alliance level, our work is to manage the oversight of the health center and the relationship with ProactiveMD. So myself and my team, my account management team, will be working with Justin and his team and the employers to manage the entire relationship, the entire clinical relationship. We provide clinic usage reporting to the employers and also the brokers. Very importantly, that integration that we were talking about before, we will help the care team on the health center identify the high-value providers, and we do so through our integration of our data with ProactiveMD. And this is unique. I know that we didn't talk about that, but typically, Justin, the ProactiveMD team connects with the TPA. And as you know, the TPA may get the data, gets the data with a lag, and that lag would be 30, 60, 90 days. The Alliance, having received the claims data for our providers first, that's kind of the closest to real-time integration that ProactiveMD can have. But of course, still they connect with the TPA to get the paid data, pharmacy data, patient liability, etc. So we will continue to support the employee education to create better healthcare consumers, and not only employee but plan participants as well, if that's what the employers want us to do. Everybody in the family is welcome to the clinic, to the health center, including minors, children above their first year of age. And lastly, of course, we recruit additional employers to make the offering more robust. As Justin mentioned, the patient panel that we want in the clinics is per provider is about 1,200. Proactive MD will be hiring a physician, an MD, and once we reach the 1,200 limit, then we're ready to hire an additional clinician. So we will have both physicians and also middle-level providers as well. And so, Justin, if you don't mind finalizing with the Proactive MD responsibilities here on this slide.
Yeah, absolutely. Thanks, Melina. So, of course, the first and foremost, we provide care. So we provide care to individuals and employees and their families. We also, and one of the things when we talk about our patient advocates, especially, we want to be that benefits concierge as a support to your HR teams, meaning we're interacting with individuals, not just delivering care, but we're interacting with your workforce and identifying those members who we can benefit the most. And we can support things like explanation of benefits so that your workforce and anybody else who's on your plan understands what options they have available to them, understands what resources are available to them. It might be the health center, or it could be any other part of your employee benefit package, such as an employee EAP program or something along those lines. A lot of times those additional benefits are underutilized. We want to understand the workforce, we want to understand the company culture, and we want to understand all resources that are available and make sure that employees are taking advantage of those resources when they need to, and so we can enhance utilization among other areas and really be that resource for individuals to be that benefits concierge. We provide data aggregation and very detailed claims data reporting. So we'll work with the Alliance to also intake claims data to measure our performance, but to also measure other areas of opportunity. You know, how well did we, not just general engagement, but how well did we engage very specific, areas of your population? What percentage of diabetics did we engage? What percentage of hypertensives did we engage? So we're looking at measuring engagement at a condition-specific level, and we're then also looking for what areas did we actually impact and save you money, and what areas are there opportunities to save additional dollars where we might plug in additional strategies. So we work in partnership with the Alliance, with our clients, with our brokers and consultants. We want to sit at the table constantly evaluating what can we do next. We call it the proactive journey. You know, once you start with us, typically the initial part of that relationship is driving engagement, awareness of service, getting more individuals using the service, and then the journey begins at that point. It doesn't end. And then we're constantly looking at, we're aware of a lot of other healthcare solutions and strategies that are out there as well, and we view ourselves as a partner in how we integrate those and make them work. So we are an enabler of good things as it relates to additional healthcare strategies, and also there at the seat, assisting with some of the consultation that goes into that. And then, of course, our integration with the Alliance. We're feeding information to them and vice versa, and working as a partner team for our clients with our brokers and consultants to make sure that we're assessing everything and using the collective teams and the thought process and talent that we have between the Alliance and Proactive MD to service our clients as best we can.
Let me, we'll move really quickly to questions and answers. We have lots of questions, and but I just want to finish this with a little story. I think the people that know me expect a personal story from Melina. So those for you who know me, you know that I like trying things before. I'm very passionate about what I do. I like trying things before I offer them to our employers, and also we're a self-funded entity ourselves. So our plan participants as well. So I have actually moved part of my care to a direct primary care physician outside of Madison, Wisconsin. And, well, I love the experience. I mean, let's forget the fact that I am often, whenever I see my physician, I'm in his office for more than 45 minutes. But apart from that, he wanted me to run some tests, do my annual lab tests. And I said to him, so are you going to give me a script so that I can go to the University of Wisconsin, which is where I have the rest of my care, to do the labs? He looked at me, he's like, why would you want to do that? It's $48. I don't know if you all heard me. because my English sometimes, but it's $48. I came back to Madison and I went to my old DOBs, and the last time I had done exams, the lab work, complete panel of lab work, the plan paid, well, the total bill was about $900, and I paid out of pocket $250 because I have an HSA. So these are the types of savings we're talking about, and I'm very excited to bring this solution to the market and to our employers. So thank you. With that, Justin, we'll move to the second portion of our webinar. I would like to ask Dan and Jake and Tina, I know Tina joined us, to unmute yourselves and come on camera. And while you're doing that, we have some questions for Justin and myself. So the first question is, and hello everybody. So the first question, Justin, is what are the considerations for employers with multiple locations?
Yeah, so there are a lot of other variables within that question. So we do serve customers that have multiple locations, and you can do it a number of ways. If each segment of their population is large enough, you can look at having a health center for each segment and each location. If it's not large enough and one segment is large enough to then have a health center, we would service the largest segment or anything that's large enough to have its own health center, and we would look for other ways to service some of the outlier communities. And we could do that either virtually through virtual telemedicine. We've deployed telemedicine centers on site, so and we've even staffed those with nurses, so you can almost recreate the entire clinical experience. And then the last but not least option is we can also partner with other direct care providers to provide a full clinical experience. And we would work with them to make sure, first we would vet them to make sure that they meet the proper quality standards to be defined truly as DPC and value-based care. And if so, we would work with them to make sure they understand the needs of the client and to vet them that they could service that client. And we would service them using a partner relationship with another DPC. So there are a number of ways that we can solve for those issues, whether it's deploying additional health centers, using virtual telemedicine technology, or partner DPC affiliates as well.
And Justin, a couple more before I go to our employers. Justin, we said, both you and I have said that we want to allow primary care physicians to operate at the top of their license. What do we mean by that? Can we give some examples where in our current system, clinicians aren't actually operating at the top of their license?
Sure. So I think if you look at the fee-for-service world, and we discussed it earlier, it's typically a high-volume environment. You have physicians that are seeing sometimes 30 patients per day, and when you have an 8-hour day, and then you also consider that a lot of your time is spent dealing with typing in billing codes and other non-care related activity, you combine a lot of volume and a lot of non-care related activity, which then minimizes the ability for the provider to actually take care of their patient. And then when you layer on top of that, maybe some administrative pressure from a health system that might own that primary care practice, it then creates a system where patients are entering into primary care and then they're quickly referred into more expensive downstream services. And so when we say we allow our providers to practice at the top of their license, first we fix the environment by reducing the volume and encouraging them to do more for their patients. And then sometimes we just have to break some habits, because if a provider leaves that world where they're used to immediately referring everything out, we want to pay attention to the numbers, and if we see an opportunity where something is exceeding our typical referral patterns, we want to take a look at those situations, and if there's a coaching opportunity for the provider, most of the time there's not. Most of the time it requires very little coaching. By simply fixing the environment and giving the providers support, 90% of the time they're where they need to be already. The other 10% of the time, we can break old habits by putting them with our medical director and any other part of our medical team to coach them up and just to simply encourage them to do more for the patients. And so when we start doing that, it means that our physicians are managing maybe a diabetic patient that they would have referred into a specialist. And they can only do that when they can spend the proper amount of time with that diabetic patient. They might be discussing medication. They might be discussing lifestyle change, you name it. There's a lot that goes into a proper care plan for those individuals. We might be plugging them into a health coach. Whatever that is, it's true care coordination designed around the patient and their specific needs, all managed by the physician. So allowing them to do what they're trained to do and also to leverage on whatever resources are available to properly manage that patient is practicing at the top of your license.
A couple more questions quickly. So what is the turnover of staff, particularly care providers, in your experience at Proactive MD, Justin?
So specifically with care providers, physicians, nurse practitioners, physician assistants, the turnover is almost non-existent. We, of course, like any other organization, we will see some turnover, but it's typically due to circumstances such as somebody has to move, maybe a spouse moves. Sometimes it's just an opportunity that somebody couldn't turn down. Our provider turnover rate, or I guess I should say our retention rate for providers that we want to keep is almost 100%. We rarely lose a provider. Once you pull them out of the world, fee-for-service world that they really don't particularly enjoy, and plug them into a good environment and then support them, they will very, very rarely leave. And this also, this is a huge point because it means continuity for the individual patient. Once patients start using a provider, they hate to see change. And so having a little turnover and having that continuity in place really does lead to much better management of the individual patient as well.
I am going to move us over to the great panel that we had on June 25th with our employers. I actually have one more question that I would like us, Justin, you and I, to address. But I'm going to actually ask Dan to help us with that as well, because I know he's doing some innovative things. So welcome, Tina, Jake, Dan. So great to see you again. So here's a question that was specifically written for Justin and myself. But as I said, Dan, I think you can help us as well. And that is, what is our philosophy with regard to holistic, non-traditional, or integrated care services? And so, Dan, you've been doing some innovative things around holistic, non-traditional services as well, right?
Well, it's a loaded question. Yes, we do things beyond just your traditional medical there. Two things that jump out that may not be in your typical clinical model. We've got a chaplaincy program as well as a mental health provider, both that we provide on site. Of course, now with COVID, we're looking at ways to try and add that as a telemedicine, and have been doing that as a telemedicine option for a while. But prior to that, they have been on site, and we're hoping to bring them back on site as COVID winds down. But we also have the musculoskeletal program that's been up and running really well for quite some time. But everything that we do, we try to make sure that it's all integrated so that our medical team knows when best to recognize that there's an issue beyond just what they're treating that may have some additional benefits to solve the problem. Weight management, for instance, may often have a mental health component to it, or may have a soft tissue component to it if a person can't move the way they want to. So we try to make sure that we're offering the services at our clinic that our employees are in need of. And often that's due to the feedback that we get from the providers. Mental health being one of those things is a recognition from our providers that, hey, you've got some people here that have some other issues that need to be addressed, not just what's presenting here in front of us.
Justin, what about our philosophy, Proactive MD's philosophy regarding holistic and non-traditional care? And by the way, I asked several times by employers on that, so that's a great question.
Yeah. So I guess, first and foremost, when you talk about holistic medicine, of course, we avoid anything pseudoscience. So it has to be science-based and evidence-based for us to consider it. But at the same time, we are practicing, I think we practice regularly, holistic medicine, meaning that oftentimes, primary care is sort of established in a box. And if it falls outside of traditional primary care, it's not that providers don't believe in it. It's that they just kind of view it as something that they would be hands off with. It's up to the patient to identify some of those alternative methods and to sort of go it alone. I think the difference is we're willing to manage the patient entirely, and that means that we're involved with their lifestyle change, their behavioral change. We want to work with their health coach, even their personal trainer. We want to get involved with things like diet and exercise, in addition to medical diagnosis and medical treatment. And so, as long as it's science-based and evidence-based, there's we highly encourage it, and we want to be involved in those practices as well.
So Tina, Jake, and Dan, I am going to come to some questions for you folks. The first one comes from Dan Adams. How does direct primary care enable and contribute to the quality of life for both the employer and the greater community? And that's a phenomenal question. You all are very uniquely qualified to answer this, because I know you're all working with your communities to bring these services more broadly outside the walls of your organization. So Tina, do you mind if we start with you?
We are absolutely trying to solve problems at Advanced Laser, but we're trying to solve problems for the wider Chippewa Valley. And so by creating our shared site clinic and also being willing to share that information to plenty of other employers in the area, I think that we're not only teaching each other, I think we're teaching our employees. I think we're educating them on how to think about healthcare differently and purchase it differently. And I think that the more of us that are banding together to undertake these sorts of activities help send a very specific message to our local provider organizations that they need to learn how to be more like the options that we're going to. So it's a slow road, but it's valuable and important work.
Jake?
I would add to that the value of the direct primary care, chronic disease management and wellness, not just for employees but for all the members, so spouses and dependents, and in a community our size that reaches out to a quarter of our community, and so we're supporting it in that way. I think another big thing for us here in Barron County was by having our own primary care physicians, we actually relieved the burden on the healthcare system in the community, where people were waiting 2 months, 3 months for a primary care visit. And so we took some stress off of the two major systems that are in our area.
And you as well, Dan?
Yeah, I don't have a whole lot more to add to that, other than one of the reasons we went with Proactive is the ability to expand the clinic to more than what it is. I've already talked with a couple of employers who want to partner with us so that their employees can utilize our clinic, and then in turn our employees can utilize their clinics in the same fashion that it's currently at. So it's something that we're, being a large employer in Marquette County, we're certainly hitting a decent chunk of the population. We're hoping to be able to hit more with that with some of these partnerships.
So thank you, folks. And also then, how did you work with your providers on educating them on your benefit plan design? We can start with Jake now.
Yeah, that was huge for us, and we spent a lot of time and effort doing that, meeting with the staff, letting them know, understand the big picture and how they fit in and what we were trying to do. And once we got their buy-in, then it was really easy. But I highly recommend flow charts and some go no-go decision making for them, because that's kind of how their mind works. That worked really well for us. And a big thing that I would stress for everybody on the call is all of our providers came from large health systems, and so they have their routines. They have people that they are comfortable referring to, and that's one of the habits that we needed to help break them of. And so we put it upon our members to handle their own referral through another partner that we have, and that relieved the burden from the staff of having to do all the referrals, but also it provided choice for the members and led to better consumerism.
So Jake, I remember when you came to the Alliance as an employer member, it was mid-year, it wasn't in 1/1, it was, I believe it was on October. And so I also recall for several months after that, we did a lot of reach out to providers, to systems. I remember many calls to Marshfield to make certain that these providers knew your benefit plan design as well, right?
Yeah, and to establish them as legitimate members of the medical community. At first, they were like Cedar Ridge. I thought that was a dental office. And to establish them, if I could go back and do it over again, I would make sure that we sent letters to all the other health systems that where we might be referring people to, or at least in the community where there would be overlap. That would be something that I would recommend.
And Tina, you're offering, I don't know if folks remember that your primary care clinic is actually through a local system, unlike what Jake and Dan offer to their employees and their plan participants. So did you have to do any communication with providers? How did you do that? How did you educate providers on your benefit plan design?
Sure. So we were part of the hiring panel for the providers that were in our clinic. And so even though we ended up going with the health system, it was good for us to be involved on the front end to find someone who we thought would bond well and be successful with our people. We have the unique challenge in that we have a shared site clinic. So there are 5 of us now in that clinic. So as you can imagine, those providers are trying to remember 5 different plans, 5 different navigations and philosophies. And so we sit down with them on a somewhat regular basis to talk about what's happening or what's next. We invite them, of course, on site to give talks or tours or just to chat with our people, both our PA as well as our physical therapist. And, we copy them on newsletters, and we ask them to provide content for the newsletters. And really, if you've selected the right provider group or the right providers, they're going to want that information. So it won't be that you're having to, necessarily push your particular agenda. If they're on your team, they want to know what your agenda is so that they can help you get there. If you have to fight too hard, then maybe they're not the right partner.
So Dan, I'm going to move on to a different question. I do recall that you have an HSA plan. How do your employees pay for the on-site, for the clinic services? And also, and of course, I will ask Jake and Tina as well. Is this also, I believe that you offer this to the employees' families as well. I can't remember if your offering is available to children as well. Can you help us with that, Dan?
So yes, our offerings are available to all covered dependents and all employees, regardless of their health care coverage. So yes, children can come in. My children have been in here on a regular basis. In fact, I had to bring my son in for a sports physical, and he really didn't want to go to the doctor. And once I reminded him that it was going to be here at our clinic, they said, "Oh, okay, then I'll go," because he just got used to it, and it's a more comfortable environment. In regards to the high deductible health plan and the HSA, only about 7% of our employees are on that particular plan. So yes, if they go beyond what's considered allowable free care by the IRS, at that point they do have to pay a fee for that particular visit. But we try to make sure that as much as what we can offer for free, we do offer for free, even as far as our medications. Some of the medications that are used for chronic disease management can still be offered for free. Of course, if it's an acute care, such as something to treat an illness, they would have to, at that point, pay the same cost of whatever that particular medication is.
So Jake, same question to you. How do your employees pay? And is the offering for the entire family?
Yeah, if you're on our Take Control of Your Health plan, then you are eligible to go to Cedar Ridge, and there is no cost for anything at our health center, including prescriptions, some durable medical equipment, some other non-traditional services that you might find in a clinic setting, but no charge for anything at our health center. And we treat, I'm sorry, our previous partner had an age limit that children had to be at least age 2. That did not go over well with our population, some of the people that need health care the most. And our new partner has no age limit, and our providers are all comfortable seeing kids age 6 months and up.
That's fantastic. I'm so sorry, Jake. We both, the panel here that's helping me, and I thought you finished. Tina, this is a question that we get, I personally get almost daily. How do employees pay? So I'm going to ask you, going to risk repetition here and ask you the same question, please.
Sure. So unlike the other panelists, probably 70+% of our folks are on a high deductible plan. Primarily, we have a young and healthy workforce, and so they're using their funds more for HSA funding versus premium. So we do have to pay attention to the cost at the Center for Health and Wellness. So for those folks who are on a traditional plan, anything that's at the clinic then is at no cost to them. For those folks on the HSA, we've done some research to take those fees as low as we think we reasonably can while still being compliant. The other thing that we've done is we also have behavioral health with our clinic, and so we're now using them as our EAP as well, so that folks that need that sort of care can start on our EAP, which is also through our behavioral health at the clinic, and then if they should need services beyond that, then when it's to cost money for those folks on our high deductible plans. But we do our very best to keep the cost as low as we can so that our folks can take advantage of the high deductible health plan options while still receiving all of the care that they need.
So one last final question. I'm going to start with Dan. It's a multi-pronged question, so we'll see whether I can ask all 3 questions here. So as an employer, do you sponsor wellness screenings at the clinic? What screening specifically, and do you get the results through an EMR?
So yes, we do wellness screenings there. Your typical cholesterol, glucose, blood pressure, also body fat, waist circumference. We do not get the results. Proactive collects the results and then gives us the reporting. We don't see individual results.
Yeah, I want to remind everybody that Dan switched to Proactive MD as the vendor who's offering on-site clinic services. And in fact, I'm excited because next week we have our first quarterly meeting, and I'm invited, so I'm really excited to see the results and look at the reporting package that Proactive uses. Jake, same question to you. You offer wellness screenings, and if so, what screenings and what type of results do you get from Cedar Ridge?
Yeah, in fact, we incentivize people to have an annual wellness exam. They get a 10% reduction on their employee contributions if they have one visit a year. And the one thing I would want people to take away is that one size does not fit all for wellness exams. And so we came up with a term, and I haven't trademarked it yet, but I may, demographically appropriate annual exam. And that's important because a 20-year-old male needs a much different annual exam than a 50-year-old female and everybody in between. And so that's a good learning point for us. And we actually invested in a blood testing machine. I forget the name of it off the top of my head. But it was a significant investment, but employees could go in, have their blood drawn, and by the time they got done with their physical, they could have the results of their blood test instead of having to send those out. So that was a good investment for us. And the last part of the question about the results, we do not get any individual results for any patient, but we do get aggregate data and look at that in combination with the rest of our population that doesn't go to our clinic and for population health statistics.
And Tina, to you as well?
Yes, so we've offered what we would think of as more of the biometric finger prick handful of measurements. We do those on site in conjunction with the clinic, although it's not our providers directly that are administering. And we do get aggregate data similar to Jake and Dan. But we're using it for those folks who haven't necessarily been up to the clinic. If they're finding individuals with some really concerning results, then they're feeding that back to our clinic, not to us, but to the providers at the clinic to determine if we need to do some specific outreach to people who, may have issues and not really realized it. So no matter what it is that we're doing, we're always trying to get people back up to the clinic to develop that relationship with the provider.
So that's fantastic. That concludes all the questions that we have received. Tina, Jake, Dan, what incredible employers you are, innovative, and always here to lend a hand and your thoughts and your innovation to other employers. I know after June 25th, many brokers and employers got in touch with you. Thank you for helping us always. Justin, I know you've come off camera, but that's okay. Thank you very much. Justin and I are making a lot of presentations in the market, so I know there's been some additional requests during this webinar, and so we will be talking to you folks. October 1st, we are going to have our annual meeting and a more lengthy, great meeting that unfortunately we're going to have to do it through the technology, which, as you see and as you know, we always have little glitches, but it is what it is. We're all here at the Alliance looking forward to seeing everybody in person again when all of this is over. But for now, October 1st, we're going to be online interacting with you. I do believe that we've sent out a hold the date, and soon invitations will go out. So I will personally see you then again. Thank you all. Thank you for the privilege of your time today. Have a great day. Bye-bye, everybody.
Thank you.
Thank you.
Thanks, everyone.